First, I'd like to give you a little background before I start about the results. So initially, we divide prostate cancer in de novo and metachronous. And as you know, de novo has been historically associated with worse outcomes, worse response to ADT plus intensification, higher rates of high disease burden. So in this study, we turned our focus more to the better half of the metastatic prostate cancer, which is the metachronous prostate cancer, where metastases occur after some time and not at initial diagnosis. So metachronous prostate cancer has not been investigated a lot, and we shifted our focus to something that we call the time to metastasis, which is the time between the surgery or radiation, which are definitive therapies, until the metastatic diagnosis, and trying to see how this time interval is associated with outcomes. This has been demonstrated in previous other cancers, such as CRC, RCC, and breast, where patients with longer time to metastases has been associated with more indolent disease courses. So here we defined the metachronous prostate cancer as the absence of metastases within 90 days of initial diagnosis. We decided to use the big database of the SWOG S1216 trial, which is, for background, is a phase 3 trial that compared the ADT plus TAC700 or orteronel, which is a cytochrome P17 inhibitor, similar to abiraterone, versus the control arm, which was ADT plus bicalutamide. So out of the 1,279 patients included in that study, we focused on 301 that met our inclusion criteria of having metachronous prostate cancer, as well as having undergone radical prostatectomy. We preferred not including the patients receiving definitive radiation because they usually receive androgen deprivation therapy with that. So we wanted to have a cleaner data set, if I might say. So our main objective was to correlate time to metastasis with the outcomes, but also to categorize those patients by thresholds and see if there is any differential effect of time to metastasis between ADT plus bicalutamide and ADT plus an ARPI, which is TAC700 in this case. So initially, we analyzed TTM as a continuous variable, but we did not see any association with OS or PFS in neither of the arms or the overall population, or the overall sample actually, with the hazard ratios neighboring 1.0 for both OS and PFS. So in our more granular analysis, where we divided TTM in thresholds of 1, 2, 3, or 4 years, we still did not see any effect, with hazard ratios ranging from 0.8 to 1.8 and confidence intervals crossing 1. And for all those thresholds, results were consistent in the ADT plus bicalutamide arm, ADT plus TAC700 arm, as well as the overall sample included in the study. So we found those results a little bit intriguing because in the clinic, sometimes when we see that somebody is metastatically recurring after surgery, after a long time, we tend to think or assume that those patients might have a less aggressive disease or or more indolent disease course. So we tried to replicate the study using our own database at the Huntsman Cancer Institute, where we included 186 patients that we have seen in our daily practice who were treated with ADT plus approved ARPIs, such as abiraterone, enzalutamide, and apalutamide, and results were very consistent with what we saw in the SWOG S1216 database. Some potential explanations for our results include that the clones at the metastatic diagnosis are usually more aggressive and they dominate the other cellular clones. And those clones are the ones that mainly harbor the driver mutations, including the AR mutations, as well as the tumor suppressor genes mutations. So whatever advantage is conferred by this prolonged time to metastasis is usually neutralized by clonal evolution. Another thing is that we know now that both ADT and ARPI are very effective at controlling both early and late metastatic onset. So what are the practical conclusions that we can, draw from this study? First of all patients, no matter how early they metastatically recur, need to be considered for ADT plus intensification. Usually, of course, it depends on a case-by-case basis, but we do need to consider intensification in everybody else. Another conclusion that we can draw from our study is that other factors such as disease burden as well as genomic profiling should have more weight in our decision-making process, and TTM should not be part of that. In the end, I would like to thank my mentor, Dr. Neeraj Agarwal from the Huntsman Cancer Institute, as well as the Conquer Cancer Foundation for always supporting early career investigator.